Hi, everyone. I'm just going to give it one more minute and welcome to the dental presentation today. And thank you for joining us, making sure that our waiting room is cleared, and then we will get started. I'm just going to give it a second here. Okay, looks like our waiting room is currently cleared. So to start us off, I'm going to go ahead and hand this over to Michelle Probert, our Director of Main Care, to say a few words. Thanks, Michelle.
Thanks, Jessica. Good morning, everyone. Michelle Probert. I use she, her pronouns, Main Care Director. Thank you so much for joining this morning. First, I just want to say to all of you who are dental providers, specifically, thank you for your critical services. I know that the past number of years have posed great challenges, and that as a state, we are not out of the woods yet with those challenges. And this is one piece of the puzzle to make sure that we are keeping our reimbursement methodology up to date. So looking forward to engaging with this work. This is a little bit geekier on the main care side, but I will note that as part of our broader main care rate reform efforts, this is actually the first time under our new rate reform law where we have gone through a rate determination process and updated a methodology and amounts, and are actually updating that methodology since, as many of you may be aware, for dental services, where appropriate, we look to commercial rates and a percentage of commercial rates. So with that, again, thanks for being here, and I will turn it back to Jessica. Okay, great. Thanks.
Thanks. Hi, I am Jessica Levesque. I'm a project manager on the rate reform team, the lead for the dental project. I use she, her pronouns. And at this time, we'd like to introduce our main care team to you. So we will round robin. So I'll turn it over to David.
Good morning, everyone. I will just echo Michelle's comments and say a huge thank you for all of the work that you've done at serving main care members and providing critical services. I know it hasn't been easy for you all, so thank you again for that. I am the Director of Data Analytics and Rate Setting for main care, so I work very closely with Jessica and the rate setting team. And I will pass it over to Phil.
Good morning, everyone. My name is Philip Dubois, Senior Data Analyst with Main Care, and I will hand it over to Corey.
Hi, everybody. I'm a data analyst with Main Care as well, working under Phil, and I will hand it to Amanda Lee.
Hi, I'm Amanda Lee, Rate Setting Coordinator for the department, and we'll pass to Kristen.
Hi, everyone. Kristen Merrill, the Acting Policy Director. I will hand it over to Kathy.
Good morning, everyone. My name is Kathy Coolidge. I am the new policy writer for dental. Have some big shoes to fill from Henry, but I will also put my email in the chat in case anybody would like to reach out. And I will hand this to Jane.
Hi, my name is Jane Brand, and I am the Provider Relations Specialist for Dental. And I will send it over to Shannon.
Hi, everyone. Shannon McGrath. I'm the Communications Coordinator for Main Care. And who's still left?
Lori.
Lori.
Hi, everybody. I'm Lori Bailey. I work in rate setting as a management analyst, too. I have my camera off because I'm a little under the weather. Nobody needs to see this. And I think that's it, isn't it, Jess?
Thank you, everyone. Did we miss anyone? I don't think so. We would, if you could take the time to introduce yourselves in the chat, everybody else attending, that would be helpful to us. While Mandy pulls up the slide deck, I'd like to remind everyone that we're recording this meeting and the presentation will be saved on our website. And we will provide the link in the chat, and we will also, it will be in the notice when when the e-notices go out. So that will be the copy of the presentation, this recording on the website. Next slide, Mandy. So we've already done our introduction. So today what we're going to go over is the rate determination process, the rate reform approaches, the scope of the rate determination for Section 25, the benchmarking phase, the rate setting phase, a draft timeline, comments and questions, and next steps. I just want to say that we will be saving time at the end of today's presentation to answer questions. However, if you think of a question while we're talking during the presentation, please enter it into the chat, and then we will read it at the time when we do questions at the end. So the 639 rate determination process was established in August of 2022, and it codifies our process and principles for the rate reform system. So this process is, it sets a schedule for a regular rate review for adjustments, and schedules or reviews are based on the rates that are benchmarked off of Medicare and other payers of non-benchmark rates. This process also ensures a review of relevant state and national data to inform rate amounts and payment models. This process formalizes a clear, transparent process for rate determination and allows for stakeholder engagement, public presentation of our rates, an opportunity for written comments. The department also responds to these written comments, and those get posted on our website. This process also established a main care advisory committee called the MAC, and it established a technical advisory committee called the TAP. Next slide, please. Okay. So this is it shows you kind of the process of the rate determination process itself. So I just want to say that not every study goes the exact same way. This is just a basic what you might expect in a rate determination process. So in this particular study, we've already done the initiation notice, which went out October 13th of this year. Today we're having our kickoff meeting, and we will talk about the timeline. In December, part of January, we'll probably be doing some data collecting and working on the rate setting, the draft rates presentation, and then we would allow for public comments. It's probably going to be in the spring. Then there'll be a final rate determination. And then in this particular process, we're going to be working on some of the policy rate rule proposal concurrently as we're doing this study. Yep, and I'm going to turn this slide over to David. Thank you.
Thanks, Jessica. As we've been planning for this this kickoff meeting and this rate determination, we have got some questions from dental providers on the different types of rate determinations that MaineCare does, and how do we decide when to use Medicare rates as our benchmarks for setting our rates, or the commercial rates as we've done with dental, or when we conduct a rate study. So I'll just say rate setting is very complicated. There's no way to capture all of the complexities in one single slide. Take this with a grain of salt, but I've tried to give some generalizations about why we might use Medicare, why we might conduct a rate study, or why we might use other payer benchmarks. Medicare, in our Chapter 639, the rate system reform legislation requirements, we are required to look at Medicare benchmarks where they exist, and that's generally our default approach if those rates are available. Obviously, for dental services, Medicare does not cover dental services. So we can't use that Medicare benchmark approach in this case. And then for rate studies, I'll just say those are typically pretty significant administrative efforts to do that data collection on the provider side. So those tend to be for services that have not standardized national definitions. They might have main care specific service definitions or staffing models or licensing requirements that require us to find a way to establish a rate where an external benchmark just wouldn't be as appropriate. And so in the case of dental, we are looking at the other payer benchmarks, and we'll get into more details about what those benchmarks are in some future slides and how we'll construct those. Next slide. So in this, for this rate determination, again, that legislation requires us to update benchmarks every 2 years whenever we do choose to use that alternative payer source benchmark to set the rates. So we set the dental rates in July of 2022 using those commercial and Medicaid benchmarks. And so this effort is to keep those rates updated. July 2024 will be the date that the rates get updated. So we're keeping on that 2-year cycle to get those benchmarks and then keep the rates updated accordingly. So kind of mentioned this, but that means there are 2 separate phases. One is really data heavy, that's actually acquiring the data, working with the data to calculate those benchmarks. And that's the work that Phil and Corey will be doing to collect the data. And Phil will talk about this in more detail, but that's a pretty significant effort just to understand what the commercial benchmarks are, what the other state Medicaid benchmarks are, and then lining those benchmarks up against all of the services that we cover. Once we've completed that benchmarking analysis, then we'll move into a rate setting phase and use those benchmarks to determine the appropriate rates that we'll be using based off of those benchmarks. So to get into more details, I will turn it over to Phil.
Thank you, David. And if we could go ahead and proceed to the next slide. So in the benchmarking phase, MaineCare will determine a commercial median benchmark for each CDT code. Commercial payer data for dates of service from July 1, 2022 through June 30, 2023 will be sourced from the Maine Health Data Organization's All Payer Claims database. The commercial allowed amount for each claim is equal to the sum of the paid amount, copay, coinsurance, and deductible amounts. For determining the commercial median benchmark for each CDT code, data will be limited to commercial payer dental claims paid as primary and claims with a rate paid greater than 0. So the median allowed amount across the valid paid claims for each code is established as the commercial median benchmark. MaineCare will also determine an all states Medicaid average benchmark for each CDT code. The rate for each service will be sourced directly from each state's Medicaid agency website. For each service, a benchmark rate is established at the average of all states' rates. And some states establish a rate differential for child and adult services. So in these instances, the child and adult rates are averaged, and the resulting average rate is used in determining the overall average of all states' rates for a service. Next slide, please. So then we move into the rate setting phase, and the standard rate setting method considers the two sets of benchmarks derived from commercial and state Medicaid program reimbursement rates in order to determine the main care rate of reimbursement for each code. The standard rate setting method first considers the commercial payer benchmark. The main care reimbursement rate is set using the commercial benchmark if the benchmark is determined to be reliable. And the reliability of the benchmark for a particular CDT code may be flagged as questionable if there's no commercial benchmark available, or if the CDT code has low commercial utilization, or if using the commercial benchmark would result in a drastic decrease or a drastic increase of the current main care rate. For CDT codes where the commercial benchmark is deemed to be unreliable, the rate setting method will then evaluate the reliability of the all states Medicaid average benchmark. And this benchmark will be assessed using the same criteria used to determine the reliability of the commercial benchmark, with the exception of a consideration for low utilization. If the all states Medicaid average benchmark is also determined to be unreliable, then the code is flagged as a potential exception, and an options analysis is conducted to determine if any of the benchmarks result in appropriate rates, or if we need to develop another methodology. Next slide, please. So the rates for dental services will be established for each CDT code based on the type of service. Diagnostic, endodontic, periodontic, and preventive services are prioritized, and rates are determined using either 67% of the commercial benchmark as the standard option, or 133% of the all states average benchmark when the commercial benchmark is unreliable. Similarly, rates for the remaining service types are established using either 50% of the commercial benchmark as a standard option, or 100% of the all states average benchmark when the commercial benchmark is unreliable. And I will now hand it back to Jessica to walk us through the draft timeline.
Thanks, Phil. So this is our draft timeline, and today we're having our meeting. We're hoping to then get the data from MHDO and get that request in there in November, review the data by when we receive it, review it in January, hoping to have a presentation back to you where we can present some draft base rates and some methodology in February. Then we would accept written comments. Usually a 2-week-ish time frame is established, depending on what else is happening at the time. So we try to be reasonable, 2-3 weeks of written comments. And then we review those and post our response to comments on our website, which I have posted in the chat. So if anybody wants to check our website at any time, there's always information, the newest information posted on there. And as I had stated earlier, the rulemaking is going to run concurrent with this process. And we are targeting 7/1/24 as the effective date for these rates. Next slide. Okay. Wow, that seemed to go really quick today. So we are at the comments and questions section of our presentation. So just want to remind everyone how to raise your hand. There's a function below in the reactions that you can raise your hand. Try to keep your comments as, to a reasonable time frame. The chat is not an official way to have a comment. At this time, if you are on your phone to dial in to let us know you're there, *9 is how we would do it. And also if you're Alt-Y is how you raise your hand on a tablet. So at this time, we'll take any questions or comments that anybody has, and I'll check the chat to see if there are any in there as well. Go ahead, Leo.
Thank you. I have a couple of questions about determining the benchmark rate. I think I heard that you were going to use the median commercial rate. And I'm wondering how the decision was made, or why the decision was made to use the median rate and not perhaps a higher rate. Very well could be the highest commercial rate instead of the median rate. And also with respect to setting the benchmark when there is no reliable commercial rate, using the average all over state rate. Why average? Why not something different from average? And I ask these questions because what I'm really afraid of is that we're going to end up with a rate that providers are not going to want to accept or adopt. And it seems to me that it might not be a bad idea to encourage providers and encourage more providers perhaps to come to Maine by setting rates that are not average, that are not medium, but are the highest rates that anybody pays. Now, I know that that's going to require a much higher fiscal note as a policy matter, but at least for the next couple of years, it doesn't look like we're going to be looking for a whole lot more resources to assist us. So anyway, those are my comments, and I've got another one about the process for determining, when a rate is unreliable, and how that really works out. And so anyway, I'm going to stop and listen to your answers.
Go ahead, Michelle.
Thanks, Leo, for your question. First, I just want to talk a little bit about this session as opposed to most rate determination sessions that we're holding. And so unlike other processes that we've been through so far, this is not actually a discussion or opportunity to address our underlying methodology. We do that for all services on a 5-year schedule. And while I certainly acknowledge that sometimes there can be a case for addressing methodological aspects on a quicker timetable, we are still in the process of going through all Maine Care services so that we can feel confident that all of our reimbursement is where it should be. So we've been trying to prioritize doing that first baseline rate determination for all Maine Care services and then getting on that 5-year schedule. So this opportunity with dental is really because we use a benchmark approach where we need to do additional analysis, since it's not, as David noted, there are not Medicare benchmarks, and so there's work that needs to be done to update those benchmarks every 2 years, and that's really what this session is about. Is that benchmarking process. So questions about determinations of reliability, which does play into the benchmarking process, are appropriate. But our selection of the initial percentage benchmarks for the commercial rates are not something that we intend to address at this time, because again, that is really revisiting the entire methodology, and this is a more limited scope. Having said that, I will just say that, as we go through all Maine Care services, theoretically, one could say that because we care so much about Maine Care services, we should always be at the top of reimbursement rates. But just from a budgetary perspective, that's not possible, right? And so we have constrained resources, and we have to take that into account when we're setting benchmarks. We, as part of our rate reform law, will be doing a benchmarking study every 5 years. so that we can keep track of how our rates are comparing to other benchmarks. And that is one of the inputs that will help us determine whether we think that a percent benchmark that we're using is still appropriate. So we will certainly assess whether at the 5-year mark, the 50 and 67%, if I cited those correctly, are where we should be. But again, our scope for this work is more limited this year.
Well, thank you for that, Michelle. You know, this is a brand new service. It is not one that we build upon, and so I think it provides an opportunity for perhaps an exception to the 5-year rule. And honestly, we all know that we have an extremely serious lack of dental services for adults, and especially older adults in this state. And it doesn't help to simply say that we're going to follow the way we always do things, even though that's a legitimate way to approach this. But it seems to me that we know that our house is burning. I mean, there are lots of houses that are burning, but this is a brand new house that's burning even before it's almost finished. But it is almost finished. People are just beginning to live in it. And it just seems to me that it might be a wasted opportunity just to continue proceeding as we normally proceed. And I guess that's why I'm making the comments that I'm making. I'm certainly aware that this is not the typical way we do things, and we certainly have had good reasons for approaching the way we set rates over the years. But, you know, new benefit, lots of people that are in desperate need, an extremely low inventory of providers, an extremely difficult attempt to get more providers to come to Maine. And there's a clear example of that with a specialty, the orthodontia example that we experienced this year with children, where, you know, there were only a couple of orthodontists in the state, and when one of them decided to stop practicing for whatever reason, I don't remember now, it took months and months and months to find someone else, and it required a lot more money than normally the organization that sponsored the orthodontia normally paid. So all of that has encouraged me anyway to be perhaps a stronger advocate for this initiative than we normally would be. So anyway, a long comment, but thank you for your answer.
Thank you for your comments, Leo. And I will say that we will need to prioritize comments that are related specifically to the benchmarking update. So would like to take those comments first.
Thank you.
Before we move on, I just wanted to address one quick technical detail from Leo's first question, which is the commercial benchmark is the median allowed amount, not the median commercial payer rate. So that's just a nuanced tweak to that question, Leo. So that does include the plan paid plus the patient responsibility. It's not just the plan paid amount. So just wanted to provide that clarifying detail. Jessica.
Hi, it's actually, there's two of us on here. I'm Dr. Kaylee Williams. I didn't get to introduce myself at the beginning. I jumped on a little late. I'm the clinical director at Waterville Community Dental Center. I had Similar questions to Leo at the first stage here, so thank you for clarifying some of that. I think my question is, again, more of a clarifying question for what our real ability is, what kind of input we're wanting to be able to give main care in this process, because it sounds to me like the main two kind of buckets of work that are going to be done in this process are reevaluating the benchmarks, and determining those benchmark numbers. And then I think I'm a little bit more confused as to how the policy and actual, the words escaping me now, all I can think of is the benefit manual itself, how I know that's going to be concurrently able to be discussed to some extent. I think I don't want to revisit everything that was just discussed, but I think from a provider perspective, our concerns are that we're very seriously struggling to find providers to meet our specialty needs, especially, and our comments are probably going to be really focused on, in general, that there is a lack of access to those specialists, and it doesn't seem like we're going to be able to make a lot of headway in making any significant change to reimbursement in those areas through this process, which, if that is what this process is, then that's reasonable, and we have to, you know, abide by the process. But is there any ability in this process to really discuss what the provider, I guess, providers are experiencing right now and how that can affect this reform? I'm not really sure how to phrase the rest of my question, but maybe there's something that can come out of that.
I will say that, again, this specific process that's part of Chapter 639 is about the updating of the benchmark amounts. Once we have conducted the analysis that the team provided an overview of, then you'll have dollar amounts, which will be of interest. And so there will certainly be opportunity to comment on the outcome of the analysis. Right now, we're just talking about the general process and analysis that we will be doing. So there will be an opportunity as part of this specific process to further comment on issues related to adequacy of rates, et cetera. I will note that also in regards to Chapter 639, unfortunately, for the purposes of this call, we actually are wrapping up this process, but every year we have a process where we accept public comments on our proposed rate determination schedule. And I fully get that the nuance of, you know, this opportunity being about benchmarking versus overall addressing the methodology may have been lost, and we will try to be more clear about that in the future, because I understand that it can get muddied. But just for future reference, if there is advocacy that, even though it's been less than 5 years, for example, since setting a rate methodology, that folks want to advocate for an earlier schedule, then that is another opportunity under the official rate reform statute in order to do that. And I will note that in terms of questions, so separate from reimbursement methodology, but talking about the benefit itself, as probably maybe all or many folks on this call are aware, we do have a dental subcommittee to our MAC, and I really see that as the opportunity to bring up concerns and ideas and solutions regarding our actual benefit, as well as more operational concerns. So that remains an avenue for those broader policy issues that are not part of this benchmarking update per se. And then obviously the legislature's coming back in session, and there are other opportunities for advocacy beyond those that that MaineCare plays an official role in.
If you have a follow-up question, go ahead.
Yeah, sorry. Additionally, I think there are other pieces of reimbursement that I don't know if this, again, is considered more methodology or part of this process, but there are like subsets even within where we're talking about like dentures, where I'm not really sure if that might meet that qualification for needing something like having an unreliable or reliable resource, or if there may be an opportunity to open up discussion about some of these cases where like I know we're struggling to be able to meet costs and provide the service in general, and that the benchmark at the certain allowance right now is really a significant hindrance. And if there's any opportunity in these discussions to point out some other areas that might be identified as needing a rate study or a different approach to benchmarking, or again, if that falls under a larger methodology, but that just comes to my mind as well as something where the benchmarking process, similar to the conversation I think that was had with orthodontics, might need to be looked at differently than it's looked at for other kinds of dental services.
Sure. I think that and in some cases you may well have a better idea than you may have a prediction at this point of how the analysis may come out, but we haven't conducted the analysis yet. And so from our perspective, it's important to have those updated numbers. It's possible that the concerns you have will still remain. It's possible that that the updated analysis may help in some of those areas. We don't really know yet. So you are welcome to especially if comments are related to commercial rates, which we are benchmarking, that those are valid comments you can make now, I think. And I should have probably confirmed with Jessica David that there is an intent to, I think we need to show the actual analysis to have a really full, to be able to accept full comments. So that wasn't part of the plant process. David, you can jump in and correct me, but I think that will be important.
Yes, so when Jessica had shared our draft timeline, that future stakeholder engagement forum where we'll present those final rates will also include the benchmarking analysis, components of the benchmarking analysis, and we can show where those commercial benchmarks landed, where the Medicaid benchmarks landed, and have those available for context as we're presenting the rates that were also based off of those benchmarks.
Karen?
I understand that we need to let the process happen, but I think, correct me if I'm wrong, Dr. Williams, but I think we're trying to figure out how to be proactive to let you know ahead of time before the process starts that these certain services, we're losing money every time we provide the service. So if you have the heads up, for example, that we're not even breaking even on a denture case, that you could take a closer look at that when you're doing your analysis. So where's the opportunity to let you know ahead of time these certain categories should be looked at maybe a little differently or in a little more detail than others, because us as providers are struggling in these certain areas. Am I making sense?
Yeah, and I'll be clear, like we are not going to, people should take this opportunity to comment what they will comment, and we don't restrict the kind of comments that folks give. And the comments that will be most helpful to us at this point relate to the process we're undergoing at the moment. And as I said, I think that your comments it may just be more informed once we have the actual analysis completed. But I'm not saying that you can't submit comments right now regarding potential concerns or what you're experiencing right now, possibly related to commercial rate amounts, for example, would be valid, because we don't know the. I'm sure you know commercial rates better than we do, since we haven't started the actual analysis of those updated commercial rates, right? So that would be helpful information to give us a heads up about information that we otherwise may not know. So going into it, if that makes sense.
Jessica or Kaylee?
I was just gonna follow up and add to Karen's comment that I think, and I appreciate your response, Michelle. I think in the short term, again, for the providers, that there are active discussions happening within dental centers across the state about whether or not they can continue to provide these services in a very short-term process, like talking about whether or not dentures or root canals or other really complex services in the next 3 to 6 months are even possible for our offices to deliver. So I think, again, we're really wanting to be as proactive as we can in this conversation. And so I appreciate your feedback, Michelle. And I think we'll really do our best to provide as much information as we have on our end to show the places where we're really struggling to make ends meet. Because just to circle back and just reiterate a lot of what Leo was saying, that the access to the services is just so strained right now that we're all having to make really tough decisions about providing the care that we're able to provide. And we are trying to figure out amongst ourselves how we can better provide these services, and also work within the confines of the structures in MaineCare, but also want to take advantage of any opportunities that we have to really give important feedback that will hopefully inform decisions moving forward for 5 or 10 years. And I think there's a lot of information, like you said, that we'll be able to give in these next upcoming phases. And it's, I think, important from our provider perspective that we want to stay really respectful of what's possible in the process, but we also don't want to unintentionally lose an ability to make a significant change that would really impact our sustainability as practices. So we'll be looking out for, and I guess just maybe, I think a lot of the providers in this setting are not as familiar with these kinds of conversations with MaineCare, and we just want to make sure that we're giving the feedback wherever it's appropriate, and are happy to help design or redesign our comments and structures in the most productive way, and look forward to having that sort of communication with MaineCare moving forward.
Are there any other questions or comments? There's nothing posted in the chat, so. I did, however, post my email address in the chat, and the last slide, I'll just say, Mandy doesn't have to pop it back up there, but is basically to say that we have just talked about it, comments. Doesn't, just send your comments to my email address. And it's not, as David had said, this part in the process where we will summarize the comments and post responses on our website page, but we're still interested in your comments at this phase of the process, and you're certainly welcome to send them to my email address, and we will respond appropriately, like individually. They won't get summarized and put together, and no one else will see our response to comments. So that's where we are at this point. And my email address, most of you should have it. It goes out on most of these notices. I've put it in the chat. It will go out on the next notice. I also have, like I said earlier, we posted the website for the rate reform page in the chat. So you can, if you check that in the next couple of days, next day, you'll have access to this video. You'll have access to the PowerPoint presentation before the notice itself goes out. And do we have any other questions or closing? Okay, go ahead, Karen.
I was just wondering if somebody could just explain to me the methodology and the benchmark for the orthodontic codes. I know we all know that orthodontics is a different beast. Private insurance typically pays a $1,500 max and the patient is responsible for the rest of the copay. So I'm just trying, I just would like an explanation, like how do you figure out the median of a commercial insurance when most commercial insurances only pay that max amount and the rest of the responsibility is left to the patient?
I can take that question. Phil, feel free to chime in because I know you did some additional analysis on this the last time we updated these benchmarks, but as I mentioned earlier in response to Leo's comment, we are using the allowed amount on the claim, and that does include both the payment from the insurer and the patient's responsibility. So that's copays, deductibles, coinsurance. All of that information is available on the claims that we get from MHDO, and we do include that full amount in our calculation of that commercial rate. So it's not just the amount that the insurer pays, it does include the payments made by the patient as well. And if I remember correctly from the feedback we got a couple years ago, the benchmarks that we created, the benchmarks themselves were kind of on par with what feedback we heard from providers as kind of the going rate, including the member responsibility, the patient responsibility. Phil, do you have anything else to add to that?
No, I don't. I think that's accurate.
Thank you.
Do we have any more questions or comments? Okay. I just want to remind everyone again that my email's in the chat and you have access to that website reform page so that you can look up any information. And I think that if no one has any questions or comments, any closing comments from anyone on the main care team, then
I'll just thanks folks again for coming, and we appreciate your comments and we do hear you and look forward to receiving your feedback. So thank you.
All right. Thank you everyone for joining today, and we look forward to your comments, and we'll see you at our next meeting. Thank you.
Thank you.